Okay, so the next thing that comes up is how do we remove an OVD? Well, you can see here from this image of a cross-section of an eye that the anatomy is pretty strange. And if this is the shape of the OVD, the IOL tends to act as a key holding this locked in position. So to get an OVD out of this space, it has to either be reasonably fluid and be able to scroll, or it has to be fracturable and come out with flow. So there are a number of techniques that were developed to remove OVDs, and the first one was a rock and roll technique, which I developed in the 80s. And you can see a cross-section of how it works in an eye. But we have a video here, and here you see it being done in a laboratory in a human eye, and the IA is being rolled gently across the lens surface, but also using it to rock the lens. And as it rocks the lens, you can see that the fluorescein stained Helon GV in this case will come out when it grabs an edge of it. And if you do it a few times, it takes like 20 seconds or so, all of it will come out and then it's completely gone. And then you can see it being done here in a Miyake view in a laboratory. And it's again fluorescein stained Helon GV. And as you roll the IA, which in this case is more difficult because you're rolling it at 90 degrees to the axis of the lens rather than parallel to the lens axis, which would make it rock more. But here you can see as you roll the IA back and forth, the fluorescein stained Helon GV comes out. So that was fine, but until we started to get other OVDs like Helon 5 and Discovisc, it didn't work so well for those. So it turns out that rock and roll works extremely well for viscous cohesive OVDs. You only have to rock the lens and tilt it like 15 degrees. But if you want to have to use for either viscoadaptives or dispersives, you have to rock the lens and tilt it like 45 degrees. So other ideas came along. One of them was the idea of Manfred Tetz to displace the lens inferiorly away from the incision and then come with your IA behind the lens, aiming the aspiration port towards the lens and doing what he called a two-compartment technique, taking out the OVD behind the lens first and then in front of the lens. But the one I like the best, of course, is the ultimate soft shell technique, because if you don't put the OVD behind the lens, you don't have to take it out. And the video that I showed you before, you saw that it came out in a few seconds. By the time I had the lens positioned, the OVD was gone. So then the next thing to consider is one of the things we often ignore. When we first got OVDs, and Helon came in 1980, Helon was developed to be able to create space and stability in the anterior chamber when we were doing intracapsular surgery and placing iris-supported lenses. So the most important thing that the initial OVDs did was create pressure in an eye when the wound was open. And pressure is a very important thing for us to remember. It was brought to our attention in Bohemian Rhapsody with Rami Malek singing and doing his great show. But pressure is critical for us in eye surgery. When we do a capsulorhexis, we have to have stability and pressure. When we do phaco, our machines raise the pressure in the eye. The same with IA, it pushes back the posterior capsule so we can take the cortex out with stability. When we implant a lens, we want to open the bag and maintain some pressure, and for many other things. So for almost everything we do in the eye, it's easier when we have some pressure in the eye to stabilize things so we can do our surgery. So if we talk about Argentinian flag sign, it's important to understand that really it's a problem that is very, very easily solved by fundamental rheology. It's not so complicated. All you have to do is make sure that the pressure in front of the anterior capsule exceeds the pressure behind the anterior capsule. And so here's a case, and we don't want to get the Argentinian flag. So all we do is we fill the eye with Helon 5, or preferably viscoadaptive, until we see the anterior capsule depress or becomes concave. And then we just paint a very, very thin layer of vision blue on top of the anterior capsule. And we do the capsulotomy. It's going to tear along the ridge from when the capsule goes from being concave over here to being convex in the perimeter. And that's just simple physics. It will always tear along that line. So if you fill it and you create a central concavity, you have no issue or worry about anything happening because it will always tear in the same place. So here you see it being done in a case. And now I'm going to fill the eye. If you watch carefully, you'll see that the center of the capsule gets a little dent. And here I just paint a tiny bit of vision blue. And you can see, even though it's not much vision blue, it's quite enough to stain the capsule really well, and you can see extremely well. and it tears right along that line. So it really makes things quite easy, and you never break the capsules or get tear outs by doing this. So the TRISOFT shell technique, you can see, actually is a sum of both of those techniques. So the soft shell technique is here, here's the dispersive, and here's the viscous cohesive. And the ultimate soft shell technique is having the viscoadaptive here and the balanced salt layer behind it. So if you add them together, you get a TRISOFT shell technique. And so here you see it in animation, where again, you add the dispersive first, you put a mound on the center of the lens, you then come back with the viscous cohesive or viscoadaptive behind it, you push the whole thing out to protect the lens, the cornea, and then you come back and you create a small lake of water where you're going to be doing your surgery. Now I tend to do the surgery in this area with this technique under low flow conditions. And the reason is, if you work in this space and your flow rate is 15, you will have the same turbulence inside the capsule to make pieces come to the phaco as if you had a flow rate of 40 in the whole eye, because the space here is less than a third of the whole space of the anterior chamber. And if you work in a third of the space, you need only a third of the flow to have the same turbulence. And so you can leave the front of the eye totally protected, and you can work in the back part of the eye without needing much movement for cases like IFIS or bad corneas with this TRISOFT shell technique, and it makes the surgery much easier. So here you see a drawing of what happens for a Fuchs dystrophy patient. The important thing here is to make sure that the entire cornea is covered by the dispersive OVD, and then you bridge the entire space with the Helon 5, a viscoadaptive, because viscoadaptives will not move if your flow rate's less than 25. So I do it with a little lake here, and I keep the flow rate at 15 to 18, and I work in this space, and there's not a single drop of balanced salt that gets washed up against the cornea. And then when I finish the case, I come and I remove the Helon 5, and I leave the dispersive OVD, because it's much better to give them a drug to prevent a pressure spike than to wash off the dispersive and thereby damage endothelial cells. So to do these cases, you keep your flow rate low, 15 to 25 cc's per minute, the vacuum low, the bottle height low, and the cases go extremely simply. And the other case where you want to do this specifically is if for Flomax cases, and you do what I call the soft shell bridge. The main difference here is you take the layer of dispersive and you extend it so it covers the entire iris. So first you inject the dispersive covering the entire iris, then you inject the viscoadaptive, then you take hooks if the pupil is small and you stretch the pupil, because with the dispersive covering it, you will get no flopping at all of the iris. You then inject the solution over here, which I use xylocaine phenylephrine. That makes the pupil round, it makes it get a bit bigger, and you do your surgery in this small space, nothing moves, and the cases become actually quite easy. So this is the order that you do. You inject xylocaine phenylephrine first as the first step through the side port, tamponade the peripheral iris with viscoat, blockade and bridge the center of the anterior chamber with Helon 5, stretch the pupil if it's less than 5 or 6 millimeters. Don't be afraid of stretching the pupil. It doesn't matter at all as long as you tamponade it with your dispersive. Then you lift the Helon 5 away from the capsule with the layer of balanced salt or xylocaine phenylephrine. Keep the rexus small, a bit smaller than the pupil, and use low flow techniques to remove the lens, as I showed you with the endothelial dystrophy. And these cases also then become routine cases. The trick in cataract surgery is to design the anterior chamber so that although you're doing different kinds of cases, you're really doing everything pretty much exactly the same with subtle differences in how you design the spaces where you want to work. It just makes everything easier for you. And to perform the phaco with the IFIS bridge, the same as the other one, you just have the same low flow rates and do it as you would in a endothelial dystrophy case. So here is an image from the paper we wrote, and it shows you all the different soft shell techniques and all the variations of TRISOFT shell techniques and the different steps in the TRISOFT shell technique, shows you how to do them, and it really allows you to do all the cases the same, but a little bit differently in creating the environment where you want to work. So that's the summary. I think it's important for us all to understand how we evolved these different OVD techniques. And although in many places people think that OVDs are excessively expensive to buy, my own view is it's way cheaper to spend $50 to buy another OVD than to have to do an endothelial transplant or to have to bring the patient back to repair a problem that occurred in surgery. You'd have to buy a lot of OVDs before you could recover the cost of having to do a second surgery or to fix someone's eye that had a corneal problem. So I think that in reality, they're quite cheap. And if we understand how we can use them, you don't have to use all of them for every case. For example, in most cases, I don't use a dispersive because if it's an easy case, I won't be doing surgery for very long. I just put in the viscoadaptive, put the balanced salt or xylocaine phenylephrine below it. I may lower my flow rate a bit, maybe 28, do the case, everything stays still, finish, go home, nothing happens to the cornea. But if I have a more dense lens or a Flomax case or a bad endothelium, then I might use all three of the layers. So judicious and careful thought of how you use these OVDs makes it not only more efficient for you, but it makes it considerably cheaper and it works just as well. So I thank you very much for your attention.
Thank you very much, Dr. Steve Arshinoff, for this great, wonderful presentation, which is full of very rich information, very guiding techniques to save our patients. Actually, because we may think somewhat in the cost of the surgery, but actually, if we spend some more money by using the OVD together with the cohesive or dispersive, the dispersive viscoelastic material, we will save our patients from the endothelial injury, which may need endothelial keratoplasty or long time of medical treatments, also with annoying time for the patient, which will disturb his and our lives. So the soft shell technique will decrease and decrease the post-operative endothelial complications. Also, will improve the outcome of the cataract surgery, about the vision and about the satisfaction of this surgery. So let me ask you about the way of injecting, or the arrangement or the step of injecting the visco material. We will start first with the dispersive to fill the anterior chamber, but
no,
keeping in mind the pressure. So yeah, this is my question.
You don't fill the anterior chamber. When you're going to use two OVDs, when you put the dispersive in,
yeah,
at most you fill half the anterior chamber, usually like a third, because you're going to use the cohesive to push it up against the cornea.
Yes.
You only need a thin layer of dispersive against the cornea.
Yeah.
And the thicker you make the layer, the more you're going to wash it out. Okay, so if you make it thinner, it actually lasts longer.
But actually, no need to direct the cannula to the back of cornea, just at the pupil.
On the surface of the lens.
Yeah, okay, at the surface of the lens, and then the cohesive will be injected inside this layer.
Into the very center, right adjacent to the lens surface. So it pushes it up.
To move it up. Yeah.
Because you see, cohesives tend on their own to form like a ball.
Yeah.
And so as it forms the ball, it will push it up into a nice smooth layer.
Yeah.
Against the cornea.
And then the BSS on the lens of service.
On the very bottom.
Yeah, and the very bottom of the cohesive. Right.
Now, people think that they can't see this. The truth is that by your second case, it's incredibly obvious. Even the third layer of putting the BSS, you'll notice a few things. If I want to put, let's say, just Helon 5 and BSS, I used to think that'd be very hard to see the difference. But if you inject it slowly and you watch the BSS slowly forms a little lake on the surface of the lens, and you see the Helon 5 layer will go up because they don't mix very well. And the more they're different, the easier it is to identify what's happening.
Yeah.
And it really is extremely easy once you've done it 2 or 3 times.
Yeah. Okay.
Everyone's afraid, oh my God, it must be so hard to get it right. If you inject on the, and one of the other tricks by doing this, there's so many advantages. And one of the neatest ones I like is when you go back to do hydrodissection, If you've left your Helon 5 layer or visco-cohesive layer against the corner, you have disturbed, and now you're going to go back and you've done the capsulotomy, and you're going to inject into the capsule. Remember that you still have that layer of the viscous cohesive. So if you inject slowly, the cohesive will direct the flow to go into the peripheral part of the capsule. You can inject near the middle of the lens, and you watch the fluid go all around the lens, because the OVD directs it for you. Whereas if you use a less viscous OVD, viscous cohesive OVD, it'll just go along the surface and go under the lens capsule, and it'd be much easier. So I just place the cannula near the capsular excess, aiming in one position, and I inject slowly, and you watch the thing go all. Can you hear?
Yeah, now I can hear, but I missed some of your answer. But actually, I got the answer of the question about the hydrodissection. If you are gonna hydrodissecting the lens, there is no need to remove all the cohesive.
No, you leave it there.
Yeah, leave it there. Okay, just slow injection with some pressure on the nucleus, not to increase the pressure inside the bag.
Right, and actually one of the tricks you can do is when you go in with the cannula, if the eye is still filled up with Helon GV, Helon 5 or whatever, okay, you wiggle as you put the cannula into the eye, because it's all in layers, right? So if you wiggle a bit, it'll make an exit path through that little incision, right? Because you're taking the cannula in and making a little hole, and that's all you need. And then the VSS will flow around the lens and leave the OVD sitting there above it.
Yeah, to lift the upper lip of the wound, of the corneal wound with the cannula, keep it as an exit for the fluid.
You don't have to even lift it. Just as you go into the eye, just wiggle back and forth.
Yes.
It takes out the OVD from the incision itself and lets the balanced salt to exit through that little flow place.
Yeah, and the Helon will still in place to keep the space and protect the cornea. So the same idea with the posterior capsular rent. If a small hole, I can close it temporarily with the viscoat, with the Helon or the.
So use a viscoat to close it. Where you have the hole, because the vitreous is there, you don't want to use the cohesive.
Yeah.
So you want to then go around the hole with a dispersive as you leave the phaco in the eye to maintain the stability of the pressure.
Yes.
And then you take the phaco out, and then you balance the pressure behind it with a little bit of cohesive, because that will block the incision. Then do your posterior capsular excess, and then you just go and finish the case. Okay,
it will save the tear from the widening and the vitreous prolapse. It will prevent the vitreous prolapse by posterior tapping of the vitreous.
Because you can push the vitreous back. Because you put dispersive,
okay.
Once you've made the posterior capsular excess, you put a little bit more dispersive, and the vitreous will go back through the hole.
And I can complete my procedure safely. I can complete the phacoemulsification without fear of dropping or increasing this posterior capsular tear. And I will, again, if I used the OVD for closing of this tear, I will prevent the vitreous prolapse. I will not need to use an occlusion, which about the safety, about the cost is much better than using the dispersive or leaving it without occluder or protection. Also about the staining of the anterior capsule with trypan blue. I asked you when we were off air about the trypan blue staining. It's for just this coloring of the anterior capsule, and you told me that it's for cross-linking of the anterior capsule to be less elastic.
Yeah, people tend to think that the best point of trypan blue is the coloration of the capsule. It's not true. That's the second best point. The best point is that it cross-links the capsule. So you have to understand that a hypermature lens is basically necrotic. It goes white because the cortical cataract starts to rot.
Yes.
And so the capsule is necrotic. That's why it imbibes water. That's why the pressure can be higher inside the capsule. Also because of the fact that when it becomes necrotic, it loses the cohesion of the cortical fibers to each other. And so the lens will want to become more round instead of being oval. So it loses its shape. That's why it tends to tear out. So if you go and you make the capsule stronger and you cross-link it with the trypan blue, first you get a few benefits. One of them, if you put the Helon 5 in front of it, it'll flatten it so it goes back to its oval shape and create a dent in the middle. Yeah. It'll cross-link the capsule so it's stronger. So despite the fact that it's necrotic, it won't fall apart. Yeah. And it'll make it look blue. You don't need that much blue staining. You saw with very, very little painting of the trypan blue, the blue is completely obvious against the white background. You don't need any more blue than that. Yeah. And so that's all you need. And the stability that you gain by putting the Helon G5 in first is the biggest advantage, because the mistake people make is they go and they make a hole in the capsule first or do all kinds of tricks to play around, but they haven't stabilized the capsule. So most of the times you get a tear. I've seen people that got tears before they did anything. They opened the eye, they put in something to make a hole in the center of the capsule. Before they even got to the middle of the capsule tore. When they touch it, it tears out. And it did that because they haven't stabilized it. The first thing you want to do is stabilize it by putting in a very viscous cohesive OVD in the front to push it back until you see a dent in the anterior capsule, and then it will never tear out.
Yeah, perfect. Thank you very much. But about the removal of the visco material from the eye, from either the anterior chamber or from the bag, so we have to remove it thoroughly and properly, and at the same time carefully when I'm dealing with the back of the lens. I tend all the time to put the aspiration cannula, and I'm using the Pi manual, not the one piece. The Pi manual can, so I'm putting the infusion cannula directed to the inside of the bag and put the aspiration cannula under the IL and move it on the back of the IL to remove all the visco material and also aspirate the visco material from inside the bag. I think it's okay.
My only comment with that would be that you have to remove the OVD more carefully than completely. There's only one OVD that was ever sold that caused pressure spikes lasting more than 1 day, and that was Orcolon. Orcolon was polyacrylamide. It was on the world market for 6 months and taken off the market. The FDA called me to go to Washington to discuss why this happened. And it happened because when they made polyacrylamide, they were afraid that it would not, that it would over polymerize. So they left some monomers and they left some polymerization material inside of it. And it kept polymerizing as it was manufactured because it was sold so you could keep it out, not in the fridge. And so what happened, it polymerized so much it didn't come out of the eye at all. It stayed in the eye and destroyed and blocked the angle. And so there's some people lost their eyes from terribly severe glaucoma that occurred with pressures of 60 and 70 post-op that didn't go down. Every other OVD ever sold, every OVD made of hyaluronic acid or chondroitin sulfate or HPMC, the pressure spikes only last a day. If you have a patient with a pressure spike more than 2 days after surgery, something's wrong. Either the patient has glaucoma and they were referred to and no one told you they had glaucoma, or else something happened in surgery where you damaged the angle. But it's not from the OVD because OVDs come out in less time than that. So the point is you must take the OVD out because you can't leave in too much because it mixes with the aqueous and will block the angle. But you don't have to take out 100%. None of us ever do. You take out 95%. The last few percent you try and you may get 97% in one case, 92 in the other case, but more or less you take it all out. The OVDs are designed that they will wash out themselves over a day or so. So you don't have to panic if you leave a little bit of HPMC or a little bit of any OVD in the eye, as long as the OVD that you're buying is completely sterile and safe to use. Now, there was an issue with OVDs a long time ago with the standards, because some of the companies from some countries who are making OVDs did not want to have to pass the standards for sterility for other surgical devices. Everything we use in surgery has to have a bioburden of better than 10 to the minus 6. In other words, only 1 in a million cannulas should grow any bacteria. When they make baked beans to sell in Africa, they have to pass the bioburden level of 10 to the minus 9, which means only 1 in a billion, not 1 in a million. And the reason they're more strict with baked beans than they are with OVDs is because if you have a refugee camp, which unfortunately occurs too often in Africa, and you give a bunch of kids 1 can of baked beans that's not sterile, you're probably going to kill a whole bunch of kids who are going to try to get the food and share that can of beans. So they're very, very rigid in the world before you can sell that to poor countries, not surprisingly. All things we use in surgery have to pass a bioburden of 10 to the minus 6. So if you sterilize your instruments, only 1 in a million instruments will have any bacteria whatsoever on them afterwards. But they allow OVDs to be sold if they're only filtered and have a bioburden of 10 to the minus 3, which is 1,000 times less sterile. But they still label them as sterile, but in small, very small print in brackets, they say to a special sterility level for OVDs, meaning it's 10 to the minus 3. Only 2 companies I know of autoclave them terminally and have them sterilized at 10 to the minus 6. And those are the 2 companies from Sweden, Bohus Biotech and the previous Pharmacia company now owned by Johnson & Johnson. So those are good at 10 to the minus 6 because they terminally autoclave them. But the other ones may not. Some of them might and some of them don't. You have to look at each package. So the concern with the OVDs leaving it behind is not only that it can cause a pressure spike, but it might not be sterile.
Yeah, okay.
So you want to take it out if you can.
Okay, but the pressure spike, as you said, it's not more than 1 day.
Right.
If it's more 1 day, there's something else increasing the IOP. Also, then the possibility or the incidence of infection or intraocular inflammation with the OVD is much and much less than what may happen from the infusion, the intraocular infusion fluid. The intraocular infusion fluid may be contaminated, so it may the incidence of infection from it is more than the OVD itself.
Depends on the OVD. You want to use infusion fluids and OVDs from good companies because they're the ones who will give you inflammation, TAS, infections.
Yeah. There was an episode for a few years ago in some hospital from the contaminated infusion. About 15 or 20 cases for a consecutive 2 days with cataract surgery. Yeah, and they found that the fluid was contaminated. So
that was in Egypt? Was that in Egypt?
Yeah.
But they had a series of cases with contaminated OVD in Canada, and they've had different ones in many countries. So my advice for that is when you buy something, make sure you buy it from a company you trust.
Yeah. Because
it doesn't take much, a few bottles of contaminated infusion solution or a few boxes of contaminated OVDs, and that makes your life miserable and the patients.
Yes, I know. The question about if I left some of the OVD inside the eye, when I agreed to use the anti-glaucoma, I know that we need to increase the outflow to wash out this viscoelastic, not to decrease the aqueous secretion. So I know you don't agree to give the patient Diamox or Sidamex, or
doesn't work,
or the beta blockers to give them a beta carpine,
right,
to constrict the pupil and dilate the trabecular meshwork and increase the outflow, or to use the prostaglandin analogs like the Zolatan or some
yes.
drop.
I give every patient a drop of pilocarpine at the end of surgery.
Yeah, just 1 drop in the fornix at the end of surgery.
I give them 1 drop, but if the patient has glaucoma, we have those little minims from Bausch & Lomb in Canada. Most countries except for the US have those little minims, little tiny things that contain 0.2 cc. So I put a drop in their eye when the case is finished. If the patient has glaucoma, I give the patient the minimum and tell them to take it again at 6 hours and then at 12 hours post-op, because that keeps them from having a pressure spike altogether.
Okay, but you will find an objection from other surgeons who may say that the prostaglandin analogs, the pilocarpine, may increase the inflammation, the intraocular or the extraocular inflammation after surgery. What's your opinion? It's worth to be worried about it?
I think I've done it in my last 20,000 cases, and I haven't seen a single patient have a problem.
Okay, without any problem from both of them.
They actually like it because I do bilateral surgery, and if you give them pilocarpine, it brings down the pupil and they can see better right away.
Yes, yes, it's perfect for the patient.
Yeah.
Visual rehabilitation after surgery.
The only thing you can't do is you can't give them 2 or 3 drops because they get a headache.
Yeah.
If you're not accustomed to taking pilocarpine and someone gives you 3 drops in each eye, you get a pretty bad headache.
Yeah, bad headache.
You have to just give them 1 drop. That's it.
From the muscle spasm.
Spasm, yeah.
Yeah. Okay. Okay, Dr. Steve, thank you very much for this precious and rich discussion and the wonderful presentation. And as usual, you are giving us your extracts of your great life experience in the field of cataract surgery. And I hope to start a series with you about the all matters regarding the cataract surgery. Also, we want to speak in another phase about the cornea and refractive surgery too. Right?
Okay.
Yeah.
Well, thank you, Dr. Osam. I'd like to thank you because I think this is the 3rd or 4th presentation I've given for you. And I just want to say that for your audience, that I think you're doing a fantastic job in trying to find not just me, but other people from around the world to help the education level in Egypt. And not that Egypt's a bad place, but I think we all gain from diversity and looking and seeing what happens in other countries. And you're the first person I've met from Egypt who's doing that in your country. And I think you deserve a lot of credit for going to the effort to do this. I know when I talk to you, it's okay for me, it's the evening, but for you, it's always 2 or 3 in the morning. And I think once we had until 4:30 in the morning. So you make a great effort for your colleagues.
Thank you very much. Thank you. It's very kind from you, and it's a great witness from a great surgeon like you. Also, it's a gold medal to put it in on my chest. Thank you very much.
You're very welcome. And thank you.
Not at all. It's my honor and pleasure to have you and to listen to you. Thank you very much. And let's arrange for the coming meeting for the audience to be on waiting. What would you like to talk about in the coming meeting?
Well, as we discussed before, I have a few other things that I can talk to you about without having to do, lots and lots of preparation.
Yeah.
I was going to just show you brief things like when I do bilateral surgery, how we change the room over so you can see what actually happens. And I have 2. I have one of them in a place we work at, which is a private place, which is too efficient. Yes. And one I worked at in a public hospital where it's not so efficient, but it still works perfectly fine. Yeah. But it takes 3 minutes instead of 1 minute. And you're probably better off to see the 3-minute ones. You see what the nurses do and how they move.
Yeah, yeah. Okay. I need to see this process.
I can show you a phaco of what happens when we get people that have soft lenses. Now, soft lenses may not be what you often see in Egypt, but as we all get better and better and do more cataract surgery in the world, we have people come to us that are 35 years old that have -22 glasses or +8 glasses. And as far as I can, +8 refractive error is just as bad as having a 20/40 cataract, but a lot worse probably. The same if you're -22. Because I had some patients come that were -22 and they couldn't wear a contact lens. So they really have a hard time getting around. So I began doing refractive cataracts probably in the late 80s. Yes. As I was doing phaco and most people weren't, and I got people that just wanted to see better.
Yeah, okay.
And as we began to do refractive surgery in 1991 with an excimer laser, some of them were -20, and of course they weren't candidates for excimer lasers, and so we had to find other ways to do them. Additionally, the Americans weren't doing refractive excimer laser surgery, and they wouldn't allow Americans to buy intraocular lenses that were negative lenses. So if you can't get a -10 lens, you can't do a guy who's -30. So I was doing a lot of Americans coming across the border for these things, and so I got to have a lot of practice in doing relatively clear lenses in people that had very severe refractive errors. The problems are different because you get a problem with a high eye probe of a very shallow anterior chamber. If they're non-ophthalmos, they have a risk of getting aqueous misdirection syndrome post-op. If they're high myopes, you need a very, very long phaco to reach back into where their lens is. It's so far back in their eye. So you have to change the pressure to lower the pressure in the eye and change the flow rate. So you're working with the lens more forward. So there's all kinds of tricks in doing them. So I have a video in showing you a number of cases with relatively clear lenses and how they work. And we could show that and discuss it. I have one video just as a case. And if you have other doctors online, we can just start it and we can stop it and they can ask questions as we go along to try to see what they're interested in. And then a few other things. So
yes, Steve. Let's tell our audience that we will arrange for a meeting in the coming weekend. We will talk about the refractive lens exchange, how to prepare my patient properly to save my patient from the intraoperative and postoperative complication of the refractive lens exchange, especially in the high myope with -22 myopia, as you have mentioned. So I want to make me a lecture about the proper preparation of cataract surgery, the cataract patient, sorry, how to prepare the patient properly before surgery regarding the dry eye, the treating of the dry eye and treating of the ocular infections and the eyelid, the lashes, and so, about your opinion or practice in preparation of the patient with antibiotic before surgery, and also the care, the post-operative care. It's very important to know how to prepare, how to do, and how to follow. So it's your promise from now to give these lectures by the coming weekend. Okay.
Next weekend? Well,
yes.
Why don't you send me a message when you want it, and I'll prepare the part for whichever you want when. Okay?
Yeah. Okay. Okay.
Okay.
Thank you very much.
Thank you very much.
Thanks a bunch.
It's a great pleasure.